Good morning, Dr. Ajit, Dr. Vijay, Madhan here.
Yeah, we got a
Ajit sir, I am
good morning. We
Subani
got a
here.
tough case lined up. Hi, Subani, how are you?
Better
We
than
got a
you.
terrible case lined up, difficult one.
Yeah, this is that OM plain
Okay,
ballooning
let's
done
hope we
and
get.
LED tight osteoproximal lesion.
Yeah.
The same patient. Yes, sir. Please tell us a brief
Yep.
history, Vijay Kumar.
So let's just go through that history. Yeah. Let's put the slides up. Get that other balloon ready.
Yeah, he's a 72-year-old guy, diabetic, presented with infraposterior wall MI, and thrombolized outside, and he continued to have ST elevation and symptoms. So he underwent a rescue PCI to OM, and his LV is severe, and he was stabilized over the past few days. And he had an additional lesion in LAD. We just brought him back for an LAD PCI.
Can we play the angiogram at the first time? Yeah. So you can see that there was the OM which was totally occluded. He came with cardiogenic shock, so the patient had an intra-aortic balloon pump inserted. The OM was totally occluded, and the LAD had a calcified long segment proximal lesion, along with lesion just beyond the diagonal, which was 60-70%.
Just go inside.
So at that point of time, my colleague planned to do just an angioplasty to the OM.
2 to 5.
And you can see that post balloon, there was some slow TB flow, but the vessel had opened up reasonably, and he didn't want to stent it because it was a long diffuse disease, so he left it on medical management, and the patient was shifted back to the CCU on an intra-aortic balloon pump and on an IV. 4 days the patient was on pump, after which the pump was removed, but the patient continued to have breathing difficulty and continued to require NIV non-invasively. So the plan today was to try to look at what we did to the OM and then look at the LAD lesion and plan what we could do for him. So maybe as we get everything ready, we had to get a few things in. So I would like the opinion of Dr. Ailan, Madhavan and Mehboob of what they would plan to do if we had to take this patient in for a procedure today.
I mean, the OM branch is a small branch. Why did occlusion of that small OM branch made the patient go in for cardiogenic shock? Or is it because the LAD was also 99% closed?
Yeah. Well, I think it's very difficult to say at that point of time because anyway, as you know, Ailan, our technical plans in cardiogenic shock, which we have now published in the Indian Heart Journal, was very clear that we always did infarct-related artery, and now that's reinstated with the cardiogenic culprit shock trial, that ideally you should just do what you should do and not do all the other issues. It's clearly the patient had a lateral MI and a posterior wall MI, so it cannot be with the LAD. So obviously the culprit was the suck, that was totally occluded, so that was open. Well, obviously the LAD could have contributed, and that is the reason that we took him back because he's been in hospital for about 7 days and still requiring NIV and Lasix infusion, and he still is dependent on supportive treatment.
Ajit
So I agree
sir,
with you, it could be partially, and that's the reason why
Ajit sir, how will you account for severe LV dysfunction with this OM? Has he got an MR?
No, he has no MR, a very mild MR. That's what we first looked at, because if it was MR, he would have gone straight for surgery. The lesion in the OM plus the LAD is contributing to his LV dysfunction.
How does the angio look today, sir?
Okay, so let me just go through the angiogram of today. Can somebody play the angiogram of today? So as you can see, the LAD is the same. The circ looks okay. There is still some ratty lesions, but its flow is there. The TIMI flow is good. So I think so that part of the story about the OM is okay, and you can see that the LAD is full of calcium, and you can see that there is disease in the LAD and it's a left dominant circulation. Wire, circ wire.
Wire, no wire, circ wire.
So just let me
DFW
start off. We did a few things before you came.
IABP.
One is that
No, IABP.
we put in the left-sided intra-aortic balloon pump just before the procedure, and that's always what we do in unstable patients, which we have on the table. So a left-sided intra-aortic balloon pump was placed. The pressure on intra-aortic balloon pumping is 140/80. The heart rate is good, stable heart rate. He's on NIV and he's up to pillows, but my anesthetist, Manoj intensivist, is managing that. He's got 100% saturation of that. I usually don't intubate such patients because sometimes, if they intubate, sometimes a crash occurs in blood pressure, and that makes things more difficult.
Dr. Ajit, are you not planning to?
And
Dr. Ajit, are you not planning to stent the OM from circ to OM? Because this patient had a lesion.
not really, not now.
Not now. But this will invariably lead to LM stenting also, hopefully, because the lesion probably starts from the
Yeah.
ostium. So
Yeah, that's exactly what we discussed now.
now, wouldn't it be better to stent the OM first and probably go on with the crossover technique? Maybe you will end up with the crossover technique as things goes by.
Well, there are many issues, Madhavan, in this case. One is that you can see that the OM is a very long lesion, and you can see that. You can play that back, please. You can see that, and you can see all the flows are good. I'm in no urgent area. Yeah. The big circumflex in the proximal area, big circumflex after the branch, and a big LPDA. I don't want to hit anything, and really honestly. I only want to just check first whether we can do the left LAD and left main nicely. And that itself is going to be a challenge because of the calcium you can see. So what I have done now is, after putting the pump, we pass the wire into the LAD, and we pre-dilated. And can you show the pre-dilatation pictures with a 2O non-compliant balloon? Can you show the balloon? And you can see clearly with the balloon that
Go back.
Did you do imaging, sir, for the LAD?
yeah, sure. So that's the second part. We just did it with a 2O balloon. And you can see that the balloon was not opening up in the middle part. Can you see that? I'm not sure whether you can see that very well. But anyway, we went up to 20 atmospheres with a 2 millimeter balloon. And then I didn't want to go into that distal area first, but you could see that the balloon is not going past that area. So I went down, because to get an IVUS picture, you need some length. So then we pre-dilated into the distal area also, just being sure that the diagonal gets not occluded. That area came up well, and then we passed the IVUS. The IVUS catheter went down. So now Avinash will show you the IVUS, and Vijay will tell us the interpretation.
Next shot, please. Next shot. No, the cranial view. So actually, after 2 millimeter balloon dilatation, we could not pass the IVUS catheter, so we had to dilate at high pressure before putting the IVUS catheter down. And so if you see that angiographic picture, we started our IVUS imaging just above the bigger septal. Can you see a bigger septal distally? So from where we have started our IVUS imaging.
Yeah.
Just start playing now. Yeah. Can you see there? So this segment looks all right. That segment just above the septal branch. The vessel size is about 2 millimeter. You can just see the 2 grids. And here, if you see carefully, the vessel is intramyocardial. just coming little proximally, you can see a lot of plaque from 7 o'clock to 3 o'clock position, bit of a calcium, and again 360-degree calcium here, and now it is around 2. Then this is a stop here. So this is the point where we have that trifurcation of LAD, diagonal, and the septal. Can you play that? Keep that angiogram playing, please. Just play the angiogram. So this is where this trifurcation happens, and there's not much disease in the diagonal ostium. At least it is reasonably open. So just keep playing. At least I'm just telling about the ostial part, not just beyond the ostium. So just see here again almost 270 to 360-degree calcium, and this is a reasonably big lumen proximally, and we are coming closer to the tightest lesion proximally, and this is LAD ostium, and if you see the distal left main also is diseased. So here the strategy should be crossover rather than a single stent. Even if you see the angiographic pictures and left main looks smaller than your LCX, so that itself says that left main is at least 40 to 50% diseased. And in the proximal part we almost have 360-degree calcium, and that is not broken well with a regular balloon. And we did an angiosculpt after that. An angiosculpt also did not give way that easily. So now we are going up with a high pressure balloon called OPN balloon. So it goes up to 45 atmospheres.
Okay, so what we are going to do is just, we've done all this, so I'll just take a shot, and then we will proceed with the high pressure balloons. Can we go live, full screen, please? So I've just wired the circ because, yeah. This patient is a little breathless, so he's on Lasix infusion, and we have the intensivist here, but he has been very cooperative as of now. So Vijay, can you just explain about this balloon?
This is a balloon recently introduced into market. We can just show that. Here, just this is from a Swiss company. Let's show this side. And so we use a regular indiflators that is goes up to 28 or 30 atmospheres. So for this one you need a dedicated indiflator that goes up to 55 atmospheres. And we have just used in only one case last week. And they say that it maintains the profile and it doesn't over expand even at very high pressures. So even if you see take a 2 millimeter balloon, it goes up to only 2.2 even at 40 atmospheres. So we are going to use that 2.5 millimeter balloon we have chosen.
Any other comments?
So retrospectively, do you feel that in case the IVAS catheter had passed without balloon dilatation, rota would have been a better option?
You see, Raylan, the only issue is that the whole lumen is too big for the rota to shave. So we'll need a big rota burr to shave that off. It's almost a big lumen. So that is the problem with the rota. So here we're going up with the high balloon.
I'm at 30 atmospheres here.
Because the lumen is good. It's not that as if nothing would pass. Everything passes. But it's just that at some point we feel it's not open. Can you hear me?
Yeah, we can hear you, sir.
I think I've lost some signal.
No, we are hearing you clearly.
Yeah, deflate. I think I've lost signal with the... Hello, can you hear me, Aileen?
Yeah, we are hearing you clearly, sir. There's no interruption in your talk.
Okay, go up here.
Keep the IVAS catheter ready, sister.
I want this one. What is that? Stent boost. Ready? think it's come up. What do you think?
Yes, yes. Maybe we'll check an IVS again. A lot of times.
Yeah.
Hello.
Hi, have you maintained contact? I think we lost
Yeah,
contact.
no. We are. It's audible. You are very well audible.
Okay. Okay. Just keep talking. Otherwise, I think I'm speaking to the wall.
No.
Okay. So this has gone up to 35. We are reasonably okay. It looks much better than the other angiosculpt and stuff like that. We're going to go up 30, 35.
Can you show the indiflator? How does it look like? The one which has got up to 55.
It is a similar one.
Okay.
Yeah, it shows up to 55. I am at 30, 35 now.
Ajit sir, how much is the cost of the balloon?
I'm not so sure. I'm sorry. I'll just check with Mr. Devi. What is the cost of this balloon? Oops.
YSL.
Yeah. So what is the cost, Ravi? 38,000. So this balloon is a bit bulky and it grabs on the wire. Okay. Having a little bit of difficulty. Can you just pull the balloon back slowly? Or just push and pull. I'll open this.
Dr. Ajit, what is the tactile sensation of the balloon? Is it looks very bulky, or because?
It is very bulky. There is no doubt, Madhavan. Even when you're pulling the balloon out, it looks a little difficult. So I have to, even to get the balloon out, I need two people to do that. So it's important that you don't pull the wire out in the bargain.
Very tight inside.
Now the plan is once we get this balloon out, we'll have a look at the IVIS
Okay.
and then have a look. So this is in fact the second case we've had a look at. So it's
For how
We're
many
also
cases you have
learning on
used the
this.
same
Balloon's
balloon,
almost
same
out,
take similar balloon? Second case.
just
second
last
case.
week was the first case we
Okay.
did.
Okay. Both cases
It's
you
very
failed.
bulky. It's like yeah, we had problems there. The balloon is out now.
Very sticky.
So very sticky balloon and very bulky balloon. So we had a lot of.
So, fluoro.
You can see that many times I pull the wire back in all this bargain.
Just go to cranial, please. So no, sir. No, it is in the branch. Yeah.
Okay, now let me take a shot first and then we'll do an IVIS. Okay.
The diagram.
What do you think?
It looks better.
Wire is in the diagonal.
The
I
wire
think
is
my
in
wire
the
is in the
diagonal.
diagonal,
I
so
think.
I'm just going to-
So would you like to keep that wire and put another in the LED? Because there is lesion in the diagonal also.
I think we should be. I think we'll be okay with that, but because I don't want to, get anything into the diagonal. Because already we have a complicated LED proximal left main. Then there's you could also, Vijay may have shown you that part of that LED which is diseased after the diagonal is intramyocardial.
Yeah. Now the normal
So
segment
now
seems.
what you're going to do is have a look at it.
The normal segment seems to be just above that septum. So the stent will have to be placed intramyocardial. So are you okay with that?
I don't think we have a choice. I think there's a lot of disease, Ellen. We
Yeah.
can't avoid that now.
Yeah. I think we'll have to keep a segment
I'll
intramyocardial.
show you the
only.
IVIS again. And So what we are planning to do is do an IVUS to see whether we are okay to get a stent now. And we will plan to do 2 stents, one in the distal LAD, in the mid LAD,
Ajit sir,
extending into the
can't
proximal
they give
LAD.
any
And,
Nicaron and or other nitroglycerin and check shot again? Whether the diagonal lesion is a
yeah,
no.
we can, but we'll give you some. Yeah.
But
Okay, here we go with the IVUS. We'll give it the Quran, no problem.
Yeah, compared to the previous image, I mean, this looks very good after the high pressure balloon dilatation. Lumen looks good.
Yeah.
Yeah. So can somebody
Live
show the
IVUS,
IVUS
yeah,
live?
live
Yeah.
IVUS,
And
yeah.
Vijay, go ahead.
Yeah, this is what I was just telling about the intramyocardial part. You can just see the arteries become small and the myocardium going around. So you can just see a lot of plaque inside, bit of a calcium, 180 degrees. And again, a lot of plaque. And we are coming close to that trifurcation point. This is the trifurcation point. You can just see diagonal at the 9 o'clock and septal at 3 o'clock. So you can just see a break at 3 o'clock. So we had a bit of a break in the calcium. And here we are just looking for the proximal part where we did a high pressure balloon dilatation. And there is a reasonably good break in the amount of calcium there. And this is the left main. So I think we can go ahead with the stenting. So we'll stent the distal part again, dilate the proximal part with a balloon, stent balloon, and the proximal part stenting extending into left main.
Proximal part, you want to leave it in the
So
mid
are there
shaft.
any other?
The proximal end of the stent, you want to leave it in the mid shaft of the left main or bring it to the ostium?
Bring it to the ostium. It's a very short left main, sir.
So we made some measurements. The distance of the distal disease to the diagonal is 22 millimeters. From the diagonal to the ostium of the LAD is 44.
No, totally 44.
Oh, sorry, it's totally 44. Sorry, so approximately we will require 2 stents because we're going to use an onyx. So we don't want to, have difficulty in tracking. So we're going to put an onyx down and we are going to select the size. Vijay, what do you think should be the distal length of the stent?
Yeah, we are planning to take a little longer stent distally. So we are planning to put a 34, 225, 34 distally. Then you select the proximal stent depending on the remaining length.
Dr.
Can you
Vijay,
run
this
that
is
last
Bhupati
picture again?
speaking. Dr. Vijay, this is Bhupati speaking. The particular picture what
Yeah.
you are showing in the IVUS shows near 360-degree calcification. Why don't we take a bigger balloon and dilate even a regular NC balloon before going for stent?
We have dilated with the 2.5 balloon because,
But this shows near 355-degree calcium except for the small cracked portion. What if the stent is not going to expand?
I think proximally we cracked it. Can you see a break on
Can
one
you see
side?
the cracks?
Yeah.
It may be acting mostly at the site of this wire shadow. And I see if you see the first balloon, it did not expand at all. The second balloon is expanded. Most probably should have given way. And we can just see, can you see a crack at 4 o'clock here?
Yeah, I could see it, but still it is almost something around
And another 2
300 degree.
o'clock?
Yeah.
Okay, so let's take a
You think the vessel is bigger than that?
Yeah, it might be bigger than that.
Because
maybe
we are not too sure about the LED size because it is all around calcium.
Yeah, exactly.
I don't think it is not more than 3 to 5 maximum, yeah. And distally it is only 2 millimeter distally.
So Bhupati, the real danger of this balloon.
And Bhupati, it is a type 1 or type 2 LED. It is not a type 3 LED.
Okay.
So let's do the first part of the stent onyx distally and then take the call of what to do proximally. So we're going to use a 225/34 onyx for the distal, okay? And I put a wire in the circ just to protect the circ when we cross over.
We'll just check once more about the balloon expansion by pull back the balloon into the left main. We'll see how it goes.
Vijay, this is Dr. Ganeshan. What's your comment about OCT? Because OCT in this patient, role of OCT, because it has better resolution than
Yeah, we could have done, sir. One is uh, patient was little unstable, so we don't want to use too much of contrast.
Okay, okay.
We have done few cases with dextran, but in this case we don't want to use any of these things.
Okay. Okay.
And the second thing is it is a very small distal vessel. I am not very sure whether we will be able to get a good flow rate and to get a good imaging.
Because it is ideally
Really, one of the relative contraindication is heart failure. This patient is in heart failure. So injecting dye and all this volume in a patient in heart failure. So it's better to use minimum whatever.
Okay.
So even with dextran, there is volume. There is volume. So I think that it's better to not use any volume when there's heart failure. And then IVUS is a better tool in that.
And in a stable patient, OCT is the first choice because you will be able to get the true vessel size.
Okay.
And
Yeah.
Here you can just see a limitation of IVUS because you are not able to see the vessel size here.
Okay.
And proximally you want to place it at the ostium. So there also IVUS would be better.
Yeah, I think.
Okay. Okay. Left.
And again, yeah, better.
So as expected, it's not going to be an easy going. So let me put my bet on the onyx. Okay, so there it tracks.
I think we are there.
We are
So
there.
it is.
Okay, there's a diagonal there, which sorry, a
Maybe
septal there.
you can come
Pull
back
it back a
bit.
bit, yeah.
We are too distal, yeah. Yeah, that's.
Yeah, I think I'll go in a bit.
Yeah. This is 2 to 5. So vessel size was only 2.
Okay, that's good. So let's take a short sinning.
So we don't want any distal dissection. This can be expanded up to 2.5 or 2.75, so it is no problem.
You okay?
Yeah.
Okay, let's go there.
Fluorescent.
So here we go with the first stent. So we'll go up to nominal first with this balloon. With the first stent. What's the nominal? So we're going to be extremely careful of going up. There's a chance of rupture. So what I'm going to do is once I've...
Because mostly that is a type, it is a very small LED, it is not extending it to the apex or beyond.
So once I'm sure that the distal LED has come up, I will stop, deflate, and then pull back the balloon into the stent, and then go up to high pressure. You know, you can go up high pressure. Go up to 20,
10, sir, 12.
14, 16, 18, 20.
The ostial part of diagonal does not have much disease. The disease is little beyond the ostium, so hopefully it should remain patent. We'll see.
Okay.
Vijay, I wish you should have done IVUS for the diagonal also beforehand.
20.
Diagonal, it's too difficult to do it, sir. But we have to dilate and this thing.
Because
so there is
the
a lesion.
history
We didn't want to complicate it too much, yeah. And
Okay.
we'll just see if it is occluding something, then we'll wire it and see.
Okay, now we are going to 20 here, and now what I'm going to do is,
diagonal is flowing.
I'll show you the diagonal.
It's flowing
There
still,
it
yeah.
is. That's good. Okay, so now you can see that the stent is deployed. You have a balloon.
And if you see carefully, even the 225 looks bigger, right? At least
Yes.
angiographically.
Yeah.
Yeah.
Okay, so now we'll go to the RAO caudal and I'll measure the length from there.
We'll dilate it high pressure here. Maybe just bring it to the diagonal branch.
Yeah. I'll do that. I just want to, yeah. Okay.
We just keep the balloon at the diagonal, so we go at high pressures and see the, as Bhubadi mentioned, we test the expansion also. Yeah.
Okay, let's go
Little
there.
bit back, sir.
Okay.
Daipa. Just get the die. I'll just check the position, so then
Yes,
we'll
sir.
inflate it. Yeah.
No problem. Take your time. Are there any other questions here?
Maybe
No, just we are watching what's going to
occluding the
happen.
cheeks.
Maybe after the
Okay.
nitroglycerin and all, at the end
Yeah,
of the
so what we're
procedure.
doing
you-
is the most... Hopefully it will look okay. We had given some Nicoran as doctors Mehboob and Subani had said. And now I'm going to just not occlude the circ and dilate it. One small check.
Maybe.
That's okay, go ahead. No problem. Anyway, we're going to start.
No, that I don't want the diagonal to get occluded. So overinflate there and diagonal to get occluded. 10, 12, 14.
16, 18, 20.
Yeah. 16.
Vijay sir, if you do so, sometimes the diagonal may get obstructed.
Yeah,
Yeah,
I'm
that's
not
only
going to
clip.
very high
We
pressure.
are not
typically
going very high. See
You
that?
should, at least before there was a flow.
Okay, now
when
we're
you
going to
do
measure
a
the
high
length.
pressure
Go to
things-
our record.
Yeah.
No, we are dilating, not dilating with the bigger this thing. So we are just going to keep with only 2 to 5.
You're absolutely correct. We are not. I'm just measuring the length now of the second stent, what it should be.
No, I think we have to push it a little bit more inside.
What? Why?
Okay, you want to keep that.
Yeah.
Okay.
Okay. So you can see that another 30 would be okay, I think.
I'll just go. So, Bhubudi, we are just dilating it to check that whether the expansion of the proximal part is adequate. Sinisa. What do you think? It is okay, or we have to crack with a 3 balloon?
Osteoproximal segment doesn't appear good, no, sir?
Yeah. Maybe we can use the 3
We
balloon.
can use a
and
3 over. Maybe Bhupati will take your suggestion.
I'll just.
Yeah.
The vessel is a little bent on the one side, so I don't know whether it is.
Anyway, let's hope that the 3O balloon does a better job than what we could.
Give a 3 NC.
3ONC. And keep 3 onyx 30 ready.
And left main size was around 4.2 millimeters. So 3 stents should be fine. So 3 onyx, it should goes up to 4.25.
12 NC. Well, there was a suggestion of rhodoblator, and the only problem with the rhodoblator is, well, we could have done it. There's no issues. Patient is in a little shock, a little heart failure. If you get no reflow, and the lumen was sort of okay for the rotoblator, but may not have shaved anything.
And it is an ostial LAD lesion, so we don't want any issues because of the dominant LCX.
Any dissection would be a disaster.
We could have done, maybe, I don't know whether this IBP is enough to support his circulation.
But I have to say, surprisingly, the patient has cooperated very well despite all this going on.
So, what do you think about doing rotablation in this patient, in a patient with recent MI ostial LAD lesion, where you have to do burring from left main, the dominant LCX? What do you think? Do you think this IBP alone is enough to support his circulation?
Suppose if we cannot cross with balloon at all.
If it is not expanded, then that is a no other go. We have to do it.
That time I
In
think.
fact, we came today with a plan to rotablate. Yeah.
But we felt it is very high risk to do a rotablation in this patient.
Yeah.
If no other go situation that is different, but we could get a reasonable expansion with this.
So this
But
balloon is
in a
different.
stable patient, rotablation would have been ideal.
So now you are going to take the normal NC balloon, not that special
Trio
NC
balloon.
that.
Yeah, all NC.
Normal NC, yeah.
Yeah, go up there, please. Yeah.
Already we used a lot of balloons in this patient. So 22, 24 with a 3 millimeter. Just do a little sinisa.
Okay, I want a Cine Vision, please. So we're just using a sync vision to check whether the balloon has come up well.
Maybe we can use an IVUS once more to see that whether it has come.
That's okay. I think it's reasonably okay from the sync vision.
And once more.
Yeah, I'll go up high to the maximum.
So 24, I'm at 26. This is a little sinuous.
Okay.
We'll come back. We'll dilate the left main part also. Because
Now I'm just going into the left main and going
we are
to
just
dilate.
dilating the osteal LAD also.
So that's when the patient may get the hemodynamically unstable.
24.
T-plate. And I'm just going to be making sure my balloon crosses easily. Go up there, 20.
24, 26.
Okay, so keep the 30 onyx ready, ma. Once more, 30. Whatever atmospheres we can get.
26, 28.
Vijay,
30.
Vijay,
Okay, so we got.
Yeah.
we are not able to appreciate the balloon dilatation fully.
Yeah.
It's a little difficult in this lab. Unfortunately, the G lab has a little problem of ours. I'm sorry about that.
Okay, so
But anyway, I can see it and mark my word that it has come up better. And we'll show you some irises to be sure that what you've done is okay.
Maybe we can just see whether we have made some more cracks in that. Quick IVUS for 2 minutes will do it. Yeah.
sure.
Do we have some time more there? I don't know.
No, you
So
have
keep the stent ready. Keep the stent ready, okay. And 3 balloon we have.
You
Keep
have
a
plenty of time.
4 means
12 to
4
1.
balloon also.
Okay.
Vijay, you have
We
plenty
have
of
20 minutes
time.
more. So we do this IVUS. Okay, sir.
You have
Patient is stable, so we thought we do one
23
more
minutes more.
IVUS run. No problem, sir. And this is if in a stable patient, ideally OCT and rotablation. Maybe Bhubadi might have seen a lot of
Okay.
impellas and other things.
On.
What do you think, Bhubadi?
It's
This patient they would have done with the impella, right?
100%, sir. There's no question
Impella,
about it.
yeah.
100%
Yeah.
impella.
Yeah. So, but
They would go with impella
and
CP.
unfortunately, yeah. Unfortunately, we don't have those. Yeah, what happened? Image on the.
Bhubadi is always fond of impella,
Okay, here we go.
what is that? PSK, PCSK, all whatnot, and LVAD. You should
Yeah,
have been
nothing.
practicing
Here we
somewhere
go.
else.
Yeah.
This
Image on.
Okay, here we go with the IVUS.
Pull back.
Pull back. So now we are in the distal stent. Yeah, give heparin 2000.
Just see Bhubadi.
Give a
It
1000,
is,
1000.
you can see some cracks at 7 o'clock position.
We are not seeing the IVUS
We
images.
could not
Now
see
it
it, yeah.
is okay.
Show the IVUS, please. Sorry.
Okay, we'll just record and show you now. Yeah. Okay.
Okay.
Stop it. Just play back. Get the stent ready, please. Sister, take it this back. Take this one back, sister. Sister, take this one back. So, can you see the IVUS now? Just play it back.
Play it back. Play back the IVUS.
I'm not very sure, babe. It looks like we have created some more cracks. This place, no. Just keep coming. The tightest part, you can just see at 7 o'clock. Can you see that? There's
Stent
a
is
crack.
ready.
Yeah.
Stent. Stent.
So we'll see how the stent expands. I don't think we can dilate more than this. Maybe we can go up with one more OPN balloon, but it is already. We use so many things. Anyway.
Okay, let's now keep our fingers crossed and hope it expands now.
So any other suggestions here?
So we've gone with the OPN at 3 to 35.
Do
And then we've gone with the 3 non-compliant to 30.
now, do you think cutting balloon will have a role
Maybe
here?
a 3 OPN balloon.
A cutting balloon. See, because
We
the
put a
calcium
2,
has
5
cuts at
yeah,
two
we
places.
put at 2.5.
But
Yeah.
it might not expand fully after stent implantation. If at all, a cutting balloon might cut at some more
It
places.
may not.
Yeah. So, Alan, we used an angiosculpt to 5, but not a 3.
And
So
an
initially
OPN
when we
balloon 2.5 and an NC balloon 3. And hopefully we get reasonable areas. With any area around 5 millimeter square, I'm happy here.
Okay, so let's now get this through.
And it was a bit expanding eccentrically, so we don't want a rupture at the hostile LED part also.
So just to tell you that I heard George Retrovec speak on Impella, and the thing was interesting was in Japan the IABP has become class 3 indication, and I said that is maybe for Japan, not for us. I think in India, I think we know very clearly that this is a very important tool for sick patients. I understand Impella is coming back. I think we got some overlap there.
Looks okay. Levo-cranial, please.
Levo-cranial, just to be sure that the ostium is covered.
Stent looks very long, and we have to come back a little bit more. So are you okay? I think we're okay.
I think I'm okay.
I'm okay.
Ostium,
Yeah, it is okay.
Yeah.
So what do you think? The position looks okay?
But overlapping is too much, I think.
I'm okay.
Yeah, it is too much. We
I
could
know.
have taken a shorter stent. Yeah.
I know.
We measured only 45 something, so it is.
Small check.
Totally you
So
measured
after that
44.
34, we should have taken a longer stent.
Already you have put 32, isn't it?
Yeah, and no, 44. Then you have to include a left main also, some 8
Small shot.
millimeters.
Small
Maybe we could have taken a 23 something.
Small shot. Okay.
Okay, yeah.
Okay, go.
That's ready.
The most
Go.
important thing is to not now cover the diagonal.
We could have changed the stent, but it is okay. I think we can just. Hey, Bhubadi, what do you think? It is expanded reasonably, right?
Other view back.
Yes, sir, definitely it has expanded well.
I'll just show. So I'll just pull
So-
that back and then go a high pressure cranial, please. PA cranial.
And keep the 3 millimeter balloon back and get a 4 millimeter balloon
Okay, go up.
going up. This two views you have seen, both the views it is expanded well.
Excellent.
Can we see that? I'm just running a cine for you so that you can see.
Maybe you can show an RAO card or something. Yeah.
That's okay.
We just give one more quick inflation and come back. Because it's occluding LCX, so we just give a quick inflation. Yeah, I think it is reasonably expanded. So 3 angles we have shown. And all 3 angles it is expanded. So it should be a good area.
How much urine has he thrown?
So maybe if you don't have an IVUS, just check 2-3 angles if it is expanded well, and should be a reasonable areas with IVUS. Yeah.
Okay.
The only problem with this calcium is you see one view it is beautifully expanded, and if you go to another view
balloon?
and it is constrained.
3O balloon, sister? Same balloon?
Particularly when you have an eccentric calcium. So what do you all do? You check multiple views or?
Yeah, at least 2 orthogonal views.
In this
at least 2 views, yeah.
in this patient, since he has severe LV dysfunction and is in shock, anyway we are going to do IVUS. We can confirm by IVUS whether it has expanded fully. I mean, do we need to take 3 views giving dye?
Yeah. No, we didn't give a dye, sir. I just check the balloon expansion. Quick inflation deflations because it was occluding LCX, dominant LCX in a guy with severe LV. Yes. So we have taken the 3 millimeter balloon. Keep the IVUS ready, sister, and keep a 4 millimeter balloon. 4-8.
We'll do a 4 millimeter, then do the
Sir?
IVUS.
And I'm done.
Yeah, you can do that.
Sister, hold that.
Come here, sister.
Nachda. I think இது ஏதோ ப்ராப்ளம் இது போயிடுச்சு. 4 millimeter balloon kudunga sir. 4.8.
So this is the problem with the non-compliance after one use, that they will lose their
Sir,
profile.
go and prepare the balloon. 4 millimeter balloon.
You go up there. And usually what you need to do is just keep the gentle pressure on 20,
So 20,
22,
22.
deflate. And usually they will go. If they don't, then we'll have to use another balloon. Go.
22.
What's the size of the balloon, Dr. Vijay?
Three
The same
millimeter
one which
balloon.
you used before. Go up again.
So if you prepare the lesion well, still you post dilate it, or
Yeah, if you have IVUS,
What is your practice?
I would directly go with IVUS and assess it if it is expanded well. The lumen area is more than 5.5 in the mid.
yeah,
and
you don't have
box
to.
segment,
Yeah.
Fine, it's not going to go. Okay.
Give a 4 millimeter balloon.
So what I'm going to do is do a photo for the proximal and then do an IVUS and see what you're doing.
We'll check the flow and remove the LCXY side. Just going to do a part for proximal, means the left main.
Okay.
If you notice pressure tracing, just show the pressure tracing. And your P wave is bigger than R wave.
Vijay Kumar, the pot you would like to do
Just
after
show
removing the circumflex wire, or you will do a pot and then remove the wire?
Ideally, we have to keep the wire and do it, sir. Ideally, just keep the wire and do it. Can you see this P waves here? It is bigger than R waves, so very high end diastolic pressures. Even even PA pressure was high, and so the stall P waves show that RV pressure also is very high.
Are you planning to remove the circ wire, or you are going to proceed with pot and remove it later? Here, a lot of calcium
What
may
do you
get
think?
trapped.
What?
With pot, it may get
But
trapped
left
between
main
the
we don't have much calcium here.
In
But left main we didn't have much. But anyway, we can remove it. Well, maybe I
Yeah.
can check the flow and remove it. Yeah.
I think we'll remove it.
Because there's not much calcium in the left main part. It is calcium was only in LED part.
Okay. So
LED
what I'm
part,
doing is
yeah.
I'm just pulling that wire back. Anyway, if you require, we'll recross it. There's no issues at all. No problem. Small check.
Come back, sir. Come
I'm
back.
coming back.
Yeah. Go to LA caudal view, please. So what view you use for left main part? Oh. So you use little lens. So we all use
Areocaudal,
Areocaudal.
Areocaudal
Remove the table.
would be the first choice, then would be
IVUS is
aleocaudal.
ready.
Plain AP will be do.
Yeah, 14, 16, 18.
Yeah.
So
we did
Vijay,
an
I used
18
to
there.
do pot with the aleocaudal
Yes, sir.
and then ostial flaring with cranials, kind of
Aleocaudal.
shallow aleocranial views.
Yeah. We also do with aleocaudal because that is a view shows ostium of L6 clearly.
Okay.
So
Go
we'll
back
do an
to the other
IVUS now. Then we needed the V post electric lay off light.
If at all Impala is available here at a reasonable cost, Dr. Ajit and Dr. Vijay, sir, would you have used it instead of IABP? I know Dr. Ajit Mullasari sir is a strong
100%.
avid believer of studies, trials, evidence. So having said that, CRISP AMI and IABP shock showed no evidence On the one hand, we believe culprit shock. On the other hand, we don't believe IABP shock and crisp AMI. How do you take it, sir?
Well, Bhupati, I have absolutely no doubt that the impeller is a superior device because it does two things. One is unloads the ventricle better than the IABP. Number two, it can give you a cardiac output which is far superior than IABP can. So there's no question about what is better. And I think that ECMO has limited use in these patients because they will not unload the ventricle, and most patients have left ventricular end-diastoles which are high. So I think the choice is really number one, impeller, and number two will be IABP if you don't have the impeller. That's it. So I have no doubt about that. And there are some people who even use the impeller first, and then once patients are a little stabilized, then go down with then go on to the IABP. So there is a PROTECT trial with the impeller, which clearly showed that it's superior to the IABP. And today it's a class 1 indication for. I think really the IABP is going to be restricted to mechanical, like BSR or septal rupture, patient going for surgery.
So show the IVUS, please. Show the IVUS.
IVUS should come there. Bigger picture IVUS. Okay, so can you see that?
Can you see here the distal part of the? Unfortunately, you missed the distal edge. There is no dissection. I think this part of the vessel we can expand this much only. What do you think, Bhupati? We are almost close to the vessel wall. Yeah.
Very well expanded.
And here it is constrained. Yeah, it is. Yeah, little constrained at that. So.
Some problem with the connection. 1 minute, sorry.
Yeah, show.
Okay.
Yeah, play. So there is a well expanded stent this part, and area should be more than 4.55 and little, and here it is eccentric expansion, and here it is again good, and it is ostium, distal left main. You're okay, and we are well into left means aorta.
What is the MSA at the level of ostium?
So maybe just a distal. Which one?
Ostium of LAD.
Ostium we have to post dilate it. We are ostium LAD. Maybe should less than 5. Yeah. We are going to post dilate it again. So distal part of the stent with a 2.5 balloon.
Or you plan to take
and
the
then
same
3 again with the high
balloon?
pressure.
Or you plan to take the same open balloon?
Yeah, 2.5 balloon we already have.
Okay.
So I will dilate the distal part of the stent above the diagonal, and we'll take a 3 millimeter balloon for the ostial LAD.
Okay, so let's get the 2.5 balloon. I don't know how much time we have yet, but
5 more minutes I think.
Okay, so let's try to do that very quickly. How much dye have we injected, sister?
120, sir. 120 ml.
Okay, so we've injected 120. I don't want to inject too much here. 2.5 balloon, sister.
2.5 balloon. Maybe if anybody noticed this IVUS at the ostial LAD, just on the distal part of the left main, if you don't keep your marker of the balloon into the ostial LAD, the distal part of the left main stent doesn't expand well. So then your distal crossing may not be very. What do you see here? So just play, keep playing. Yeah, so you can just see that distal part of the left main stent not expanded well. So maybe we could have kept a little bit inner. So ideally you have to keep that marker in front of the carina. Then we could have gone little bit in with a 4 millimeter balloon.
Anyway, we'll put a 3.0 and go high pressure there.
So what do you think?
I think you should have a
Okay,
4
so here's your
millimeter balloon.
2.5 coming.
4 millimeter balloon.
Okay, so we'll use the same 4, no problem.
Yeah, we are going to use, we used it already. The position was not very appropriate.
So here's the first balloon going in 2.5. And then keep the 3O balloon ready, sister.
3O balloon and 4 millimeter balloon again, sister.
And go to the diagonal picture, cranial, where the diagonal is.
So we're going to start our dilatation just above the diagonal.
Okay, it's beautifully going.
Yeah.
Small check.
Yeah, I was
Go
check
ahead.
this. You have to come back a little bit, sir. Come back a bit, yeah.
Okay,
So this part alone 2.5, then after that we'll dilate with the 3 millimeter balloon. 22. Yeah.
finally go in a bit.
Maybe you can go in a little bit, but I don't want this diagonal to get occluded. So
Let me go up there.
Yeah.
Don't get it, so let me go up.
I'm not going up too much.
Yeah.
10, 12.
Deflect. Okay. 3O balloon system.
Get the 3O balloon, please.
Vijay, we have 3 minutes more.
Yeah, we're
Yeah,
just
sir.
going to quickly do the 3O and 4O and finish. Oops, sorry. This is what happens when you start hurrying the case. Oops. Okay.
So almost we are done. We just dilate the proximal part with the 3 millimeter balloon. And then I repart with 4 millimeter. And we are not planning to cross into LCX.
3O ready.
Good, 3 millimeter balloon. Good. Okay, negative.
It's I should congratulate the Triple M team. It's a real chip case. Excellent decision to do this case live.
Well, thank you for Jawar sir and everybody to give us this opportunity.
Thank you.
Anyway, still you have 2 minutes. No? 2 minutes.
Okay, we'll dilate with the 3 millimeter balloon, and we're just worried about the proximal LED stent expansion, but fortunately it has expanded well. Just give some areas just distal to LED, arterial LED. We are going to dilate the arterial LED part anyway now. It is.
Show me the last shot
4O sister
if the
ready.
time goes off.
Yeah,
Yeah.
yeah, we are just keep the 4O balloon ready. Connect the other one, sister. Another
20,
deflator.
22,
22 inside, sir. Maybe we'll go a little inside.
22.
22, 24, 26.
Deflect.
Yeah, we'll dilate the arterial LED again, sir. So arterial LED, I'm dilating at high
4O
pressure.
sister.
26.
Deflect.
What is balloon ruptured?
Okay.
Flow is flow. We'll just check. We'll remove it, sir. Remove it quickly, and we'll check the flow.
So the balloon did rupture there. So we have to be a little careful when you do these things.
We'll check the flows. It's sticking, sir. It'll come out.
Problem is with these non-compliant balloons, when they rupture, the balloon will stick and wrap around the wire. You have to open your 2E. When you do that, yeah, okay.
The balloon has come out fully. This is the system.
Okay, the 4O balloon.
We'll check the flow.
Let's take a shot.
Pressure remains stable. I'll just check the flow. Flow remains good. Yeah. Come to caudal view. 4 millimeter balloon. So you are done. Maybe last dilatation.
Vijay, I see some haziness in left
time
main.
is
Is it a streaming effect or something? In left main?
It's a streaming. It's a
It is a
streaming.
streaming.
Okay,
sir.
okay,
It is flowing. Both the branches are flowing. So just now I checked.
okay.
Okay. Go up.
No, sir. We have to come
So
back
one
a
check.
little bit. Yeah. Leave a caudal, please. Quick. Yeah. I think you can see
Yeah.
both the branches are flowing.
Hold it. I think we should not go more.
Yeah, that's okay. Yeah. So we kept
Mudinyachu,
the balloon in front of the Carina, balloon marker in front of the Carina. I'm going up 18, 20, 22.
And out.
Down, yeah. Okay, we'll do it.
Quick
Nivus.
and picture.
Yeah, and if a time is up, we'll give a
Yeah.
picture for you.
Yeah. You can give one picture to us.
Yeah, yeah. We are just removing the balloon. We'll give a picture. So it is DR. It's DR.
Show me AP caudal view.
Okay. Okay, AP card.
Dr. Vijay, how much ACT are you maintaining?
There's about
We gave 100 units per kg, and up by 1,000 units now.
Excellent.
So what do you think? Looks okay, right? It is reasonably okay, I think.
take the other cranial view. PA.
Yeah, cranial. And I think we are done. We do one more IVS run off live, and
Show me the distal area. I want to see the distal. Yeah.
yeah, ready. So all the branches are flowing, and angiographically at least the stents are well expanded.
IVUS. So if there are a few minutes, we'll just give you a quick IVUS. If there are, if not, thank you very much.
Okay,
You
Dr.
will have a
Ajit and
minute
Dr.
to see the
Vijay.
left main part of the IVS.
Can we take 2 minutes more? Can we
Okay, they
take
will
2
have to.
minutes?
Yeah, IVS.
IVUS is almost in. So if you give me 1 more minute, we'll give you the IVUS.
Okay, fine.
Just we'll do a manual pullback.
I'll just give you a quick pull back in a minute. You
Just
really want to
focus on
look
that.
at the left main and the.
Yeah,
Oh,
Okay.
slowly, sir. Slowly. Come to caudal view, please.
This is the other problem here. We'll have to always watch.
Because it's a calcium, lot of wire bias and resistance. Yeah. Maybe if it doesn't go. Yeah.
Okay, go. Here we go.
Yeah.
So you have to loosen the guiding.
Okay, ready?
Don't deep throat the guiding when you have this problem.
So I'm doing here manual pullback. Can you see the stent? Stent is well expanded.
yes, good.
Activate pull.
Good, very good.
I'm pulling back. Pull eccentric.
Big picture,
expanded.
big picture. IVUS full picture.
I was big. And this is the ostial part of the LAD. It looks well expanded. And I'm coming into the distal left main. It is eccentrically expanded, but still the lumen areas are good. The proximal part looks very good. Yeah, this we are into the left main, means aorta. So what do you think? Looks good.
Good, very good, Vijay. Good.
Okay.
Okay, Vijay, Dr. Ajit, thank you
Thanks,
very much
Madhavan.
for
Thanks.
wonderful case demonstration. Thank you very much.
Thank you. Thank you so much.
Thank you. Thank you very much. Last shot.
Every day, a large number of people, both children and adults, experience medical intervention and care at Triple M. They walk in through the doors of Triple M as patients and walk out with a new lease on life. The Madras Medical Mission Hospital,
Maybe you could have
since
taken 4
1987,
millimeters
has
but
been
it won't have any
synonymous
difference,
with
but anyway.
excellence in patient care and quality medical treatment at an affordable cost. And it continues to draw a large number of patients from various stratas of the society. The Institute of Cardiovascular Diseases, ICVD, at Triple M has many firsts to its credit, including the first adult and pediatric heart transplantation in the private sector, percutaneous pulmonary valve implantation, first bilateral lung transplantation, first Ross procedures, first Batista procedure, and so on. The Institute is made up of several departments, including departments for adult and pediatric cardiology and surgery, and a department for cardiac rehabilitation. It is also home to some of the finest cardiac specialists in India. The catheterization lab at the Cardiovascular Diseases Department is a state-of-the-art facility that brings in a multidisciplinary team of doctors. It is here that diagnostic angiographic procedures and therapeutic interventional procedures are performed. With every surgery performed, with every patient treated, the Cardiovascular Diseases Department at M reinforces its commitment to its missionary values. Every patient that comes in for treatment at the department, from a day-old baby to a 90-year-old, is an opportunity to further the Madras Medical Mission's goal of reaching out to the unreached.